Hey guys, welcome to the Tetra Health and Performance Podcast. Today we have a fantastic guest. We've got Michael Phipps from Zone 34 Physiotherapy joining us today to discuss a really fun topic, right? And something that's probably affected us all once or twice in our training history, talking pain and injuries. Pretty in-depth topic, but Michael, could you just first start off by just introducing yourself and what you're doing at the moment?
Sure. I've been a physio for about 10 years now. I initially started off in public health at a large public hospital in Sydney. I moved into a private practice and I've worked in a few private practices through Wollongong and Sydney now. The entire time I've been dabbling in a bit of sport, ranging from park sport through to professional sport. So I worked with semi-professional rugby league and professional rugby league for about 2 years. And I moved into professional basketball, so I worked with the Illawarra Hawks for 2 seasons. And then just recently I've started working with the Sydney Flames in the WNBL. And started at this new practice, Zone 34 up in Lewisham, and that's where I am at the moment. So professionally I have interests in all aspects of pain, injury and performance, so tendon pain in the general population, knee reconstructions and rehab following that, and just any sort of physical complaint that affects athletes and the general population.
And just before this podcast, Michael, we were just chatting, and we were talking about kind of the research that Michael's kind of delving into at the moment, and some of it is fascinating. So he was looking into knees, and in regards to pain and injury, Michael, if you want to just kind of run through a little bit about what you've been reading about knee injuries, especially ACL injuries.
Mm-hmm. So probably some of the most cutting edge sort of research coming out in the musculoskeletal area is probably to do with the management. Comparative management between surgery, injections and exercise rehab, and just taking one as an example, looking at the need for an ACL reconstruction, and that's historically Australia has done the most ACL reconstructions in the world, so we're above the US, New Zealand, comparative Western countries, but we have 3 randomised trials now comparing surgery to not having surgery. And there doesn't seem to be too much, as a very general observation of that, there doesn't seem to be too much difference between surgery and non-surgical groups. So that would probably come as a surprise to the vast majority of people that would be listening. So
yeah, I think that's so interesting that you may, and it all depends, we've kind of discussing this even further, it all depends on how you get that approach towards going to surgery or not going to surgery. Yep. It depends on who, the whole process is quite amazing. Once you do experience pain, your first step is going to dictate a lot. So your first step might be that you go see a GP, for example, and that GP says to you, I'm going to refer you on to a surgeon. And then that surgeon is maybe, sees this as an issue that needs an operation, and therefore you get the operation. And what we're seeing with this information that Michael's talking about is that you have the same likelihood coming out of a surgery as you do having what, Michael? Would it be just nothing, or is it actually going to see a physiotherapist?
You probably a 3-month rehab plan. So the minimum cutoff for any knee reconstruction would be at least 3 months. It usually takes longer, much longer, but at least in the research trials that we have, they subject people to at least 3 months of rehab. So we know after that point, and the outcomes are measured at around 1 year, 2 years, 5 years, and there doesn't seem to be too much difference between the groups if they've had a RECO or not had a RECO. But they do a structured rehab program, regardless. Yeah.
And what's the interventions there? Is that once, twice a week with the physiotherapist, or?
I think generally in studies they usually do at least 2 supervised sessions just to make it sort of create continuity.
And you did mention something about actually studies that show that actually not doing anything as well can have there's some information on that as well.
Yep. So a few years ago they produced a few placebo-controlled surgical studies. So one looking at meniscus. So there's a few now. So one's looking at meniscectomy for people with knee pain, and the other's looking at subacromial decompression for people with shoulder pain. And they usually are 3-arm groups. So they have a group that receives a surgery, so they'll receive a meniscectomy or a decompression, and then I'll have a group that's had a placebo surgery. So that's literally where the surgeon opens the person up, does nothing, and then closes them up again. So it's a placebo surgery.
I did not know that was a thing.
Yeah.
Holy crap.
I read one a while ago on knees as well. That was like a 50-50, but it was with rehab as well. And this one was not with rehab afterwards?
No. So they do, those two groups also receive rehab following both procedures. And they usually have a third arm, which is just a wait and see group, which is just tracking the natural history of people with shoulder pain and knee pain. And there's no difference between placebo and actual surgery in those populations that have met their criteria.
Do you remember how big that sample size was?
They're huge sample size.
Oh, wow.
And there's three, there's multiple, I haven't checked it recently a few years ago, but there was like 3 large RCTs looking at meniscectomy. At that stage, it could be more now. But you'd have to remember that these are certain populations. These are people over the age of 30 or 35 that have gradual onset knee pain and have a meniscus tear on an MRI. So it's not an acute meniscus tear in a 20-year-old.
Yeah.
Same thing if I jump back a little bit with the ACLs. We're not talking about an elite up-and-coming athlete at the age of 20 that doesn't have surgery. We're talking about a specific general population.
Yeah, and when we talk about that specific general population, and like you kind of painted the picture, we have these kind of younger maybe athletes who we need to get them playing faster than that. Like they're going to have a really intense kind of like progressive overload back to get them back playing again. And then also, like when you're in your 30s, you're going pretty well. Like you're still recovering and healing pretty quickly. Yeah. And then we look at the kind of the older age group who they kind of like, I say, get back into play, but they have to get back into their lives and they have to be able to do all these things to function as a human being again, and they recover slower. So there's definitely, no matter what, the process of rehabilitation is always going to be like different regarding these factors, right?
Probably an important note, it might lead into our discussion too, is that, once upon a time, the average life expectancy was probably 30 or 40 years old. So we start to show, every person starts to show degenerative changes about the age of 30, maybe 20s or 30s. So that's like wrinkles on your skin. On the inside, it could be a meniscus tear, could be disc changes, could be anything, could be small tears to tendons and ligaments. And so if you were to blanket do, scanning on that population, the odds are that you may find something. Yeah. So to assume that problem needs surgery is a bit of a jump.
Yeah, this is something else we were discussing just before as well, is how like when we look at like kind of MRIs, X-rays, and when you are, for example, you're sent towards a surgeon, or but like maybe not before a surgeon, you're looking at an MRI or an X-ray. Well, there's actually there's a lot of information now to be looked at to say that actually, well, it creates like a nocebo effect. Do you want to explain that a little bit, Michael?
Yeah. So nocebo is the opposite to a placebo. So a placebo is a reward response. So if I frame something in a positive light, that if you do this exercise or if you do this surgery, or if you take this drug, you're going to get a great outcome from this, then that's creating an expectation that you should feel that. So it has some sort of effect on the way you perceive that intervention. So the nocebo is the opposite. So it's where you create a negative framing for a topic. So it's like, you should not do this exercise because you will injure yourself, or this drug has a lot of side effects, so I would avoid it, or surgery has a lot of consequences, so I would avoid it. And so you create this negative framing or negative thought process that dictates your expectation, your experience with reality at that point. So that's,
it changes your whole experience, how your nervous system's perceiving it. Are you going to be upregulated, downregulated? Obviously, the fear and anxiety that can exacerbate. Like, especially if this comes from a trusted source, someone that you respect and someone that's been integrated into your life for a long time, their words carry weight. And if they are using this type of framing with you, it can really change your whole experience. So having trusted professionals that, again, you trust and they're going to give you a detailed breakdown and not going to like oversell it or undersell it is a really important aspect. And that's in regards to like all aspects, like your own physio, your doctor, anyone that else is involved in your health and lifestyle changes. You need someone that can kind of really be careful with their language and select their words carefully with how they're going to interact with you.
Yeah, and I think kind of everything we've covered just there is the kind of the perfect opening, if this is the opening now, into pain. Because any of these surgery interventions, where did they start? They started with pain signals. They started with this kind of like alarm system in the body. They started with people being like, I did this hurt. Or like sometimes I did very little and this hurt. And like what we kind of want to get around today is like, why pain? Kind of what is pain? And this is what we got Michael in today to speak about. And go Michael.
Can we start off with just what is pain?
What is pain?
Sure. Yep. So So we have an international organisation called the International Association for the Study of Pain, and they would say their definition is an unpleasant sensory or emotional experience. Okay, so that's the definition of pain. So basically, it's a subjective. To break that down, it's just a subjective experience, isn't it? So
yeah, I love how that, like, you're seeing that more and more now, how they're putting emotion in there. It's like not everything is like I would probably be wrong to say this, but a while back there would have been like a physical feeling of pain. And nowadays everything's kind of like looking at that biosocial model where we're looking at humans being so much more complex. We are starting to be like social, like emotional, like pain, which is like extremely interesting that when you say that.
Yeah, it sort of moved from a bottom-up to a top-down approach. So once upon a time, it was like you touch the fire causes the pain, versus now we're sort of thinking you touch the fire, your brain and your nervous system interprets that process and then creates a pain response, whether it's, if it's of value at that point in time, based on the other factors that you experience in your life.
Yeah. And what you touched on there too is also the subjective nature of pain. God, we've met some people that are tough SOBs. And you're like, hey, you look a little bit uncomfortable. Are you okay? Like, no, I'm all right. I'm like, does that hurt? No, not at all. You sure that doesn't hurt? No, 2 out of 10. And that's like a 9 out of 10 for someone else. And some people can like really grit and bear it. And then on the other side of the fence, some people are probably a little bit more susceptible to being, to feeling sensations a bit stronger and probably feel things a bit more in tune with their body. So everyone's a little bit different with their kind of relationship with physical and emotional pain. And
pain being such a complex word anyway. Like right now we're kind of talking about that like you said, that physical, emotional pain. And we're pretty all thinking the same thing in our heads right now, but I've trained people who've done a lunge and been like, that is really painful. That ow, that hurts. And I was like, where does it hurt? And it's like they just literally cover the quad muscle, and like this is really burning. It's like, and really it's very new to them, so it's a new experience. Maybe they're kind of like shocked by the feeling. Yep. But we've done 1 or 2 reps, and you're really starting to feel it in your muscles.
And right? I feel like after, like the next day afterwards, like, oh, how did you feel after yesterday? Oh, I was in so much pain. Like, oh shit, okay, let's explore this. And it's just DOMS, right? Yeah. But like people experiencing short-term discomfort, which dissipates afterwards, versus acute, long-term, like owie, this hurts right here kind of pain. Mm-hmm. 2 very different experiences.
Yeah. Well, yeah. So the subjective nature of it, is, it makes it super complex. Yeah. Do you want to touch a little bit more on what is pain, and kind of like maybe let's talk from our lens. So we like to think of that we have like a bit more of a movement lens, a biomechanical lens, if that, and like from our lens, could you maybe express what pain is from a more of a biomechanical standpoint, but then also like the complexities that pain does not just exist from a biomechanical standpoint. It also exists in many different factors. Like we call pain very multifactorial.
Mm-hmm. Yep. So pain, the first thing to understand would be pain would be a multifactorial phenomenon. So it's related not just to the muscles and our joints and our perception of the physical aspect of life, but also our psychology, our beliefs, our mood, our affect, and then through to our relationships with others, the environment we're in. That all impacts on how we perceive the world and our experience with pain. And sort of you were asking about how does the biomechanical relate to things. So there's a few models for pain, okay? And we can't go through them all, but one of the more biomechanical model of pain that's most contemporarily accepted now would be that if you do something that exceeds your tissue capacity, you're more likely to experience a noxious stimulus that will cause and be interpreted in some people as pain. So the best example would be that if I run for 5 kilometers each week and then I increase it to 20 kilometers a week all of a sudden, and then I start getting a sore spot pop up, it's probably because I've exceeded my tissue capacity. So the feedback loop is that your body's saying you need to pull back a little bit, you may need to revise your training protocol. Like that would be the traditional biomechanical model for pain. So and that it makes sense. People do experience pain because of that reason, but it's not the only reason.
Yeah, and they come like when we train, we use words like frequency and intensity, and when you're saying that, you can kind of look at pain in that way as well. Like if we have a certain tolerance in our tissues, well, we can overload that tolerance with frequency. So that could be the amount of volume that you do in a space of a day or 2 days or 3 days, like you said, like a long run. But it can be also an instantaneous intensity. It can be that you overloaded the tissue in one specific moment or in many moments over time, right?
Yeah. So there's a model. So Scott Dyer is an American orthopedic surgeon who sort of discovered a model or thought of the model of the tissue homeostasis or envelope of function. So I'm not sure if you've heard of this, but so basically the idea would be that load can be applied in intensity or it can be applied in frequency. So if you jump off a building, the load intensity is very high, but it's only one rep jump off a building, isn't it? Yep. So then you might fracture your kneecap or something, versus the load could be very low, like climbing a hill, but lots of steps going on up that hill that's now cause your kneecap pain. So he would sort of state that anything that goes beyond that theoretical point is tissue overload or super physiological overload, and that line is adaptable. So that line can retract or can push forwards depending on how much you expose yourself to that stimulus. So if you're doing lots and lots of hill climbing, the amount it takes you to exceed that threshold point where you're going to experience knee pain is a lot higher compared to someone that does it on a couch all day and then goes and climbs a hill. Yeah.
Yeah, so like we have that adaptation moment as well. Like while we are training, we are giving ourselves enough volume to actually adapt to that volume. And what happens is then I can supersede it. I can actually do more volume later on. But then the dose, this is not mentioned enough, but the dose is the effect, right? Like you can overdose things, you can underdose things, and the dose is so important.
The dose makes the amount of the poison. What's the buddy?
The dose makes the poison.
Yeah,
right?
there we go.
Yeah,
there we
100%.
go. And this is controllable, right? If you can control your outputs, so you can control your hill climbs, the amount of times you go into the gym, or whatever it happens to be. Somewhere like our facility, we really control this through programming, and that's something you can do yourself, like control what your session looks like, control how reps creep up or how intensity creeps up or drops off. And you can really manage how much exposure you have to this. Where it does get a little bit different is maybe if you have a chaotic environment that you're involved in. Now, things you can't control, bodies flying left and right or flying into you, that's different. Like playing a contact sport, for example, like you got a big 120 kilo islander running at you and hit you when you don't see it. Holy shit, that can wreck your day. Yeah, so there are things that we can control and there's things that we can't.
And other things that we can't control is often is our social environment as well. Like the stresses of our social environment. Like we often talk about, you have this kind of like anabolic, this kind of ability to build muscles up. And well, you're going to need that. If you've had a tolerance and you want to build adaptation, then you're going to need to be more anabolic. You're going to need to be in a rest, digest kind of state where you can build more muscle tissue. And then if we're in this more of a chaotic environment and we're having issues at home, we are overly more stressed, then what's going to happen is we're probably not going to be able to repair muscle as well. And actually what's going to happen is exercise or training and volume and intensity is going to become less adaptive, and it's actually going to start breaking you down a little bit more, and you will be able to handle less volume, less load. Michael, would you agree? Kind of.
Absolutely, yeah. So there's multiple variables in our lives that determine how sensitive we are to the ability to adapt to training, isn't it? So, if you're sleep deprived and you're training really hard, you're going to really struggle to cope with it, aren't you? So. Yeah.
That's why actually I've seen so many studies. I haven't really delved into them very hard, but I've seen so many studies pop up of how a limited amount of sleep really is, especially for athletes, right? Like this is actually normally done with athletes, and athletes generally need to sleep more than the general population anyway because of how intense their training is and how, again, they need to adapt to their physical requirements. But you actually see quite often that athletes, when they get something like 6 to 7 hours of sleep, they are more prone to injury. And I think that's fantastic because that's a nocebo on its own as well, isn't it? Like, it's like, there you go. Yeah. Oh, you got 6 hours sleep, you're going to get injured. Like, I think there's also, we got to be careful with this kind of information, how athletes get that type of information. Yeah. Michael, you work with athletes. That's probably not something you actually tell them, is it? You probably tell them the benefits of sleep, but you're not going to always tell them the downsides of sleep, are you?
Agreed, yeah, because especially in some athletes that tend to be hypervigilant of every aspect of their life, that it can just be a negative constant reinforcing a negative aspect that they might not be able to manage very well, and that just creates more stress. So I think, you're right, framing it in a way that it's, you can do these 3 things to make yourself a more resilient athlete and be able to cope with training loads and be able to be injury-free as best as we can control this season versus you're struggling at these things.
And you mentioned hypervigilant athletes, and we train mostly general population, and there's hypervigilant general population, right? Like the way I turn my back to one member sometimes and say something to one member, I'll turn around with a different face and say something completely different to another member, because that's what we find ourselves doing a lot. Like you need to train harder, and then go over to someone else. You might have to take a softer approach to that person because Or sometimes you might be pulling them back. Like, it's like your approach really, really matters. Like, and one thing we get as a coach is we see people 4 or 5 times a week. So I think we know, you eventually know the members and you know that kind of word, how you're going to frame this. Well, one person you probably could say to, like, you could say that to one person, right? But then don't say it to the wrong person. Like, you could say to one person, hey, like, things will happen. Like, you probably don't want to not have less than 6 hours sleep because you won't recover as well. And you might even touch on injury. I normally wouldn't, but even say, for example, for some person you might, that probably wouldn't cause issues to that person. And then when we get into people when we haven't really met someone yet, and then we start saying things, you have no idea about that person's kind of personality to even understand how they're gonna approach that when it's said to them.
All right, great segue here. We'll talk Star Wars.
Go.
I feel like this way, like
Michael, are you a Star Wars fan?
I am.
Yeah,
there's times to be a grey Jedi, times to be a Jedi, and times to be a Sith. And I don't know someone. You're playing grey Jedi. You're playing both sides of the fence. Like, very careful with your language. You're just listening more than you're talking, and you're observing how you're going to interact with this person. And then, like, sometimes you got to go a bit Sith, dude. You got to go a bit hard, and you got to go in there and go hard in the paint. And other times, everything is airy-fairy, everything is lovely, and we're playing that Jedi side of the fence. Anyway, I just really wanted to use a Star Wars analogy here.
Well, it made sense to me. Yeah, I got it.
And to tie this back into what we talked about earlier and like how you see a trusted individual, if they know you and they kind of know your language, know your personality, they should know how to tailor their language. Exactly what James was just saying there. So having that rapport is such an important thing here. And again, seeing someone that doesn't really know your background and then they say something that's a little bit alarming, you're like, oh God, okay, maybe this might be worth just meditating on for a while and maybe getting a second opinion and then see if these opinions correlate with each other, or are they contrasting, and do I need to further, find out the answer here?
Exactly.
It's, like, Michael, for example, yourself, when you deal with, like, athletes, what was the way that you normally manage pain with an athlete? What would be the first thing that happens?
That's a tough one.
It is a tough one because I suppose it matters.
It depends on the athlete, and it doesn't even matter if they're an athlete or a general person. I don't think things change too much. I just think their capacity to do activity is the difference. So, in some athletes will hold on to a label, just like some people that aren't athletes will hold on to a label. Like you may have to say, there might be an athlete that you can say, all right, you've got this tear of this muscle, and that it doesn't phase them. They're like, oh, it doesn't matter, I can still play through this. I'm happy to push through this. I'm happy to sort of persist. Whereas you say that to another athlete, and then that might just be completely disabling for them, and they might just induce fear. It might induce a bit the response to pull back and to not want to train, or to seek another opinion, or to lose trust, or it's just like a normal. There's no real difference between an athlete and a normal person in that aspect. So. What about a situation where the person really wants to play? Like, is there like a pain? I've heard it a lot, right? A pain scale, right? And I feel like the pain scale. I'd love to know your opinion on this, because I feel like the pain scale, again, like we just spoke about subjectiveness. Well, a 1 to 10 scale is probably the most subjective thing in the world, because whereas one person's 10 might be another person's 2. Is it something that you like? Is there a time and a place to push through like pain? There definitely is. So pain is a part of life. We all have to endure pain to some degree. So we're all going to experience pain in our life. We all have to push through some level of pain in our life. That's, if you didn't do that, you just would be trapped and, disabled by the, lack of experience. The pain scale itself...
Pain is life.
Yeah. Mm-hmm. The pain scale itself is not a great scale. It probably doesn't measure what we think we're measuring. You could say, in their studies they've done where they apply stimulus to, 50 people, like it could be a hot, like a burn, a mild burn, and then they rate everyone's subjective pain, on a scale from 0 is no pain, 10 is the most pain you could ever imagine. And you just get complete varied responses in the amount of pain that people are experiencing or reporting. And it's probably not because that the pain or the experience is that different between the people. It's just that the reference point is not validated. Does that make sense? So if you think of it, if we draw if we compare it to the RPE, if you're an elite athlete, you're going to have a pretty good idea of what a 10 out of 10 RPE is. If you're a person that hasn't exposed yourself to pushing yourself to the complete limit, doing that RPE, asking that person to do an RPE is probably not. It's probably lacking some sort of validity.
What's the word? Like that word for finding when you
anchoring.
Configure. It's like a kind of configuration, isn't it? Like an anchoring. Like I think of like a seesaw, kind of like the flat seesaw. It's like this is your go-to area, kind of like. And you're saying that people don't really know their starting point, or as much.
I've done some pretty hard training in my life, and I felt like what a 9 or a 10 is, but then I've seen childbirth, and I'm like, I've been nowhere near a 10. I haven't even touched an 8 or a 7.
You didn't experience it, so you don't know.
No, and this is just subjective viewing. I'm like, holy shit, this is the worst thing I've ever viewed. This is horrible. That's a 10. But like, talk about anchoring, and then I've been re-anchored. I've now re-experienced what that scale now means to me.
You've re-anchored through osmosis, so you weren't actually there to experience it.
Through osmosis, yeah, exactly. So that can change rapidly. That changed within like 24 hours.
And just to add, so we've got the anchoring of the pain scale, but then we also have the individual pain experience, which is highly variable between people. And I think you guys were alluding to that before, but doing an activity that's painful for one person could truly be a more painful activity than the next person, and that's based on a multitude of variables. It's based on as we discussed before, the biopsychosocial nature of pain. It could be their ability to cope at that point in life because they may be stressed or may have a mental health concern, or maybe they're fatigued and tired and haven't been sleeping well, and then that lunge was the last straw that broke the camel's back for them, and then that's their experience at that point in time.
So with the idea of like that lunge that broke the straw that broke the camel's back, is there anything in particular that are your big signs of like, hey, I need to stop this guy, or like, hey, do I work around? Do we so in here at Benchmark, that's what we do a lot. Like, so if someone's experiencing pain, it's normally like, oh, like a heel wedge or something like this. Like, I'm going to try and express maybe the ranges that I want from them better. And some of the easiest things in the world, like we can get into a little bit more biomechanics of it, but some of the easiest things in the world to do is like, oh, just drop the load. Oh, okay, drop the range of motion. Okay, let's do less reps. Like let's slow down the tempo. Oh, maybe speed up the like. There's all these different very easy things to do. But is there a time where you're going to be like, nah, this is like, just stop doing that?
It would be if the person had an acute injury. So say, for example, they had twisted their knee had blown up, it was like a balloon. There's clear signs, objective signs of tissue damage. So that's probably the first time that you would say, definitely no.
Yeah.
The second time would be that their pain is trending in a direction despite the intervention that's been provided, and it's just not improving. Then I would be looking at, and I'm not getting them to cease completely, but you're just scaling it back, aren't you, to a point they can tolerate. That's probably the two, or if you're concerned that there's something sinister going on. So that would be the third time. So if you're like, well, I don't think that this, so say for example they had a fracture or something, okay, and it had developed over a period of time, and that you just really needed to take all the weight off that leg. That no matter how you scaled it, this person just needs a time period just to cool off, right?
What are the next steps after that? Say the interventions aren't providing the result that's after, and we talked about surgery options after, but when do you go like, okay, now we need to have a look at maybe an MRI or some sort of a scan or look more detailed?
Yeah, or when do you say, okay, well, your goal is to build strength, right? So as often as we can as an athlete or as a general population, let's put some muscle on the body, let's get you moving as well as possible. So when would the goal then be like, okay, and we have this kind of like this bucket of rehabby exercises, right? When might the goal be like either what Mitch said, like where, okay, let's get the MRI, let's get the scan, or when would it be, okay, let's give you some movement that I think is going to strengthen this or move this a little bit more into a coordination of what I think you're going to get better movement out of? Like, where's your thought process with that?
So probably one of the things to establish is that's probably not driven by the patient, so the person's subjective experience. So if they come in saying they're a 10 out of 10 pain versus they come in just saying they're a 1 out of 10 pain, that doesn't determine the need for a scan. So the person who has 1 out of 10 may need a scan more than a person that has 10 out of 10 pain. So it's probably mostly based on the mechanism of the injury, the mechanism of the complaint, the physical signs. Is the joint deformed? Is there high evidence that there could be a fracture? Or, is there a bump on their forearm? Have they just had a recent fall? Like, that's an obvious scenario where that person probably needs to have their arm splintered and go for an X-ray. In the person that comes in with a gradual onset of symptoms, it could be extremely painful at that point in time for them. They have no physical observational signs that are concerning, like there's no swelling, there's no joint limitation, there's no change to the skin, like there's no deformity, anything like that. Then and we do a physical examination of them, and then there's really not much to be found beyond the point that they've got a painful joint. That person is probably going to benefit from a graded rehab process.
Nice. Nice breakdown.
And say, for example, a rehab process. Like I always think it's really interesting to bucket rehab exercises, because sadly, when I think of nearly any exercise being just beneficial towards the human, like most of the time, and I think all exercises should be to some level graded. But at the same time, I do have like in my head my own thought of what a rehab exercise is. And when I've been to a physio and I've been given like external rotations with a band for a shoulder dislocation that I had, I think like they get put in my head in that kind of bucket. Like in your mind, like what is the rehabby process and what should it look like?
To me, it would be a process of one, pulling back to a point where symptoms settle, and then building things up gradually. Simple as that. Like, and that can be in any shape or form. And I don't believe there's such thing as a rehab exercise. There's exercise, and that could be anything. So there's no such thing as this exercise is a rehab exercise versus this exercise is a strength and conditioning exercise. It's more just the application of the intensity, the exposures, the frequency of that stimulus.
And their goals, right? Like so for example, athlete or not, we want to get people moving pretty well, and it's kind of hard to just say, oh, well, this is good movement, right? So it's kind of like, oh, well, when I do this hurts. Well, let's put them in positions that doesn't hurt, and graded exposure is the way forward. Like, what can you tolerate right now? And over time, most people. Do you have any studies on that or anything? Because it kind of like looks like you've been kind of like looked at that a little bit, like how graded exposure leads to. Like, because there's information on like being able to pause outside of range of motion strengthens the range of motion like 15 to 20 degrees out of it and stuff like that. So we don't have to go into range to strengthen range, right?
And the thing is, the great thing about graded exposure, like there are studies, but you don't even need studies because we all have experiences of graded exposure.
Yeah.
So just think of the first thing that comes to my mind is like a martial artist that's kicking bamboo or something. So their shin is super tough after multiple exposures to that stimulus. And, if you got me to do that, it'd be excruciating painful. Maybe I'd break my shin. So that's just a process of graded exposure, or even just a runner. So building up your running tolerance, and someone that runs a marathon, they've exposed themselves to that over enough time that they can tolerate that. So, every human is adaptable, and every human can go through an exposure process to develop resilience to a task.
Yeah,
so
that is beautiful, and we do all have like everyone can picture like we all kind of know that doing that the improvements are tenfold.
And we've seen there's probably a side of the physio world that's like, stop, you got an injury, stop, don't do anything. Yep. And there's so much left on the table if you stop. So like a lot of stuff we can work around, and like we said, just graded exposure. You can still get that person moving, but if you stop, there's so many health benefits that are now left on the table. There's all the strength, hypertrophy, all that sort of stuff. There's the energy system work, the cardiovascular work that we get from training. And if you stop and if you're just resting to that point, we're leaving all this extra stuff that has greater health benefits on the table that can still impact our health and lifestyle to a massive degree. So I think it's a massive question. You then go, oh, what can I do? So rather than like, oh, let's stop, but what can I still do? What can I still expose myself to? So a question...
And the answer would be you can do everything, like eventually, but for now, like we're just going to limit this. Like, because I think too often it's like, we all know it, like don't deadlift. You should never deadlift again. You will break if you deadlift, or fragility, like actually letting people in any way think their body is not robust and tough at any age, right? Like again, like graded exposure is you're just always just a step away from finding the right load or dose for you to be able to handle. And there's no load or dose there's not. I think, so for me, I think strength training is such a weird thing. Like the word put on it, like people are so scared of it. Like the fact that like the second you've got 1 kilo dumbbells in your hands, you think you're strength training. Well, for someone, that 1 kilo dumbbell just is not enough, right? And then for some people, that is the perfect place to start. But then once they got some people look at 1 kilo dumbbells in their hands being like, oh, this is strength training, this is too much. And other people will look at it like it's
nothing.
Yeah, it's weird, isn't it? It's like there's always a level where you should be starting. And I think, personally, everyone should be starting and putting some muscle on their body.
You said the word there, fragile, or fragility. I think the opposite of that is anti-fragile. Great book, by the way. And like the ability to be robust and to be strong and to be resistant and to still persevere and make these adaptations and changes where need be. That's massive. That's the pursuit of being a healthier, more well-rounded individual. And there's always an option on the table for the person to keep going.
It's kind of like makes me think of the next question for you, Michael. It's kind of like, so we have that kind of anti-fragility, and we have these, we're talking about active modalities to rehab. What about these more passive modalities like painkillers, things that handle inflammation responses? And what's your thought process with that stuff?
So just simply painkillers, they work in acute pain. So they're designed for people that have acute pain. So if you have a sprained ankle, or if you've broken a bone, or if you've had a surgery recently, that is the purpose of a painkiller for acute pain. Where they start to fail is when pain persists. And there is definitely a role for pain management with medication in persistent pain, but it is not as clear-cut as when someone has recently had surgery. So you go in for surgery, you come out of surgery, you've got plenty of painkillers. The idea is that if you've had a surgery, we want you to move again. We want you to be exposing your body to normal life again. So we don't want pain to be a limiting factor. Whereas when pain persists, we know that the protective purpose of pain is probably no longer there.
Registering, right?
Yeah, it's no longer registering. So we want to be exposing ourselves into pain, so we don't necessarily need to kill pain. Yeah. If that makes sense.
Yeah, because I've heard stories of people taking painkillers for like such benefits. Like, I'll just go to the GP. The GP said, "Oh, well, how about this is bothering you? Take some painkillers, some ibuprofen for a couple of days, and then 3 days later, that issue never arises again." Which is fantastic, right? It's kind of like you want that to happen, but also like, with the understanding of pain being like an alarm system, we want that alarm system operating most of the time, right? Because there's loads of diseases and illnesses in the body that are registered with pain. There's some that actually manage to get not detected by pain, which is for their evolution. But the idea is that there's lots of things that do get detected, and we want that kind of alarm system on nearly all the time, right? One of my favorite kind of analogies is kind of like that, if I'm being chased by a bear and I trip over and I twist my ankle, then I don't feel that twist of the ankle because my brain is being like, hey, what is the most dangerous thing right now happening? And it's the bear.
Run, bitch.
So I'm just going to keep running. And then probably when I escape the bear, I'm like, oh God, this sucks. The ankle hurts.
And that comes from Butler and Mosley, doesn't it? So they would say in their book, they would say that pain is a threat response. So if the threat at that point in time is not you dying from a sprained ankle, it's the bear killing you. So there's no purpose in you feeling ankle pain at that point in time. So you have that ability to continue on. And there's heaps of anecdotes about that sort of thing happening. For example, a lot of that research comes from world wars, where people get shot or they get injured, quite severely on the battlefield, and they don't notice they're injured until they're back to safety, where they're missing an arm or they've got a bullet hole, and then that's the threat. The threat is at that time they're going to potentially die from that injury, but on the battlefield they could still be wounded. Yep. So yeah.
So with the idea of painkillers, would be saying that like you said yourself, is like the aim is to get off the painkillers so you can start registering, if need be, yep. Right? If that's and then the idea is eventually to be able to register pain again.
True. Yeah, yes, it is true, but it's important that people work with a GP or a pain specialist. If they're on long-term painkillers, there is a gradual approach. It's a graded exposure, isn't it? Again, so that's what it is. But there's a gradual and systematic approach that they should go on in guidance by their GP or pain physician to reduce their pain medication. Because there is, for example, certain drugs are associated with withdrawal effects and dependency and things like that we want to make sure that is managed closely by a specialist in that area. But it's an interesting one, because if I have a headache, I would take Nurofen. Like I'd rather, especially if I have a busy day at work or something, I'll take Nurofen just to get some pain relief, and it typically works well, doesn't it? So
I've never I'm just one of them weirdos that just never takes anything for anything. Yeah. I was just like, the girlfriend has to go at me all the time for that, but I'm just like, nah, just gonna struggle for it.
Yeah. So my threshold for taking Nurofen would be low if I have a headache. Yep. So I'm happy just to taking that. But if my headache is persisting for a period, and I'm relying on Nurofen to help me every single day for a period of time, it's probably some sort of thing that I need to address. And that's when I think that, like you were sort of alluding to before, that's when I think painkillers maybe do fail us in that persistence of problem, when you're not addressing the root cause.
Yeah, I wasn't so much alluding to that, because I think that it just has a place, right? And it's just like everything that exists has a place, and just to use it like when it's needed, not use it when it's not. Obviously, make sure you follow a GP's recommendations with anything when it comes to that stuff. Yeah. And it's always very beneficial to go see your GP regarding pain. I just also think that sometimes it's that first instinct of getting pain and where you go, which is going to dictate your journey with pain. And that first journey with pain is then going to dictate and build beliefs later on in the future for how you deal with pain again. And sometimes for example, you do get stuck with the wrong person. Like you might go to a GP recommends surgery happens, right? And it could be like that same person could go down another line where they go to the GP recommends exercise physiology, or they recommend, because they might see it as a weight thing, right? You know, and it should be often that can happen, right? Or it could be seen as, okay, well, this is a muscular tendon thing. We're gonna send you to a physiotherapist, right? And like, it's so interesting how there's so many different ways that you can receive pain, but there's also a million different routes that you might get when you get pain. So, Michael, what would be your recommendation for someone who has pain? Like, and then with that recommendation, think about what paths they might go down, and then what they should kind of think when that happens, if you know what I mean.
If we understand pain as a multifactorial problem, then it has disciplinary management, doesn't it? So it's especially when people have persisting pain, it's probably fair to assume that there's multiple factors that are contributing to their situation. So say, for example, this person is overweight, then maybe seeing an exercise physiologist or a strength conditioning coach or a personal trainer is a great option for them to help manage their problem. If it's an understanding of why they have pain, or if it's related to movements, or it's related to some sort of activity they're doing, maybe seeing a physiotherapist is a good idea. If it's something that's completely resistant to activity and disabling for them, then maybe they do need to see a pain physician. Okay, maybe they do need some medical management. Or if they have underlying depression or anxiety, and then that's affecting their ability to do activity and be functional in their life and their activities, then I think maybe seeing a psychologist or a psychiatrist is probably the way to go. So it is a multidisciplinary thing. So very often someone that's in pain will need to have multiple support mechanisms in their life to help them to manage this.
Yeah.
Where is that caught? Whose job is that? Is that something, if you're having a chat and you're getting those red flags of this person might need some real emotional support, is that in your wheelhouse to go, hey, maybe you should go chat here, or go chat to your GP to then refer to this?
I think it's in everyone's court. We can all identify, symptoms of like a depressive disorder, and more than likely it is impacting on their pain if they're here for pain. So to have that discussion with that person and say, like, I think you would benefit from this, because even if it's, people are always worried that you're saying to them that, the pain's not real and that they're somaticizing or there's something along those lines, but to say that it will help you with your ability to cope, like even if it's a secondary ability to cope, then that creating that dialogue at that point in time and sending that referral. And I don't think it has to come from anyone specifically, but sometimes what I will do in a very practical sense, I will address the fact that maybe this is contributing to the situation. I'll write a letter to their GP, and then I'll send them to their GP for like a mental health plan or something like that.
I think you just broke that down so well. Like, you just explained all the different kind of like the healthcare system. You literally, but then use to its best of its ability, rather than these kind of like, we're skipping spots. Like, we're not asking the right questions at the right time. We're not trusting in a network of being able to send someone to the right place because this is their job. And I suspect this. And like, worst case scenario, you suspected wrong, but they go to someone, they don't need that, and then they go down another path down the line, rather than the one path that could lead to life-changing decisions.
And that's that low-hanging fruit. You're just going like, oh God, I think this is the most impactful avenue that you can go down, and the best way to spend your time to get the best return on investment.
Yeah, exactly.
Talking about David Butler and Mosley, is like, one of the most interesting things I think that they express about pain is that understanding pain. And that's actually kind of like the first thing is, when you have pain, is you should have some, or just try and get some education on pain. And the issue with education is that where are you getting your information from? But like they say how it reduces the threat value and improves management of the pain. So just the understanding of, hey, this is what pain is, and that it is multifactorial, allows people, just hearing this, allows people to then think, wait a second, so I experience this kind of like chronic pain all the time. I experience it here, and like there is many factors in play. And it's like, there's nothing wrong with experiencing pain, first off, right? It's there for a reason. If we didn't experience pain, then we'd all be in a lot more trouble the day to day.
And a really good, just want to quickly add to that, James, is we've all had it. I've had injuries. I think we've all had injuries at some point in time through training. They come and go. And when they stick around for a little bit, we see someone to help us out and we address what needs to be addressed. It's quite normalised. You don't have to think, oh shit, the world's crumbling down, I've got this injury, this absolutely sucks. we can always bounce back from these things, and we've all experienced it, and we've ebbed and flowed with it as we've all trained and gone through life. Delivery. Yeah.
Yep. No, I agree. It's pain is, we all experience pain, and I think, right. So we need to accept the fact that there's a team around us that we can utilize to help us to manage it, and really sometimes, sometimes I do see a patient or someone, and they are maybe in the wrong place. Your exercise or seeing me or addressing pain in that sort of setting is appropriate, but they may get more value out of seeing an exercise physiologist or a strength and conditioning coach. Like maybe they just need that sort of consistency and that accountability in moving and exercising and losing weight and managing the weight. Or sometimes that's a psychologist, that's the underlying sort of low-hanging fruit that they really need to address.
And something that we've always wanted trying to, I don't feel we've been super successful with this yet, but it's something we plan on doing more and more in the future, is like I see the kind of like, what do athletes get over what general population get? Well, they get a network, like in one building. Well, that can't be done in the private kind of sector with just general population. But what we can do is we can try and have this network between trainers and how they speak with the GP, which is definitely a line that needs to be like drawn at some stage, and get as much speaking with GPs as possible, but also the line with your exercise physiologists, your physiotherapists, all these people, so that what can happen is then you know the right place for the person, and then you do the best for the individual rather than the best for your financial gain, right?
Oh, exactly right. Like you'd be like, oh, I could not refer this person to this gym, and I could just book them in for 10 sessions of physio or whatever it happens to be. People are greedy. People are kind of horrible. Not everyone's looking out for your best interests, and that's confronting, and it sucks. But that's what vetting your health professionals and people you trust is so important. Because once you do get your health network, holy shit, it's a powerful thing.
Yeah, and we refer to, like, Michael's from Zone 34, and we refer to Zone 34 from vetting. Like, we've done a lot of it, and we believe in their process. And just speaking to Michael at the beginning of this podcast before we started as well, he mentioned how, like, they have their own vetting process, obviously, at Zone 34, and how most of them have done quite a lot in their careers so far. They've worked with athletes. And I think one of the things of working with athletes, even though I don't think it's required, as we were kind of saying how that you have to get things done with athletes. So you normally have a physio who knows how to get things done, because you have a timeline that this is business. Right?
This player's getting paid
you get
X
this
amount
player
of dollars.
back on. So, and they're not even just, that might not be the same approach that you take with your general population, because you might need to take a different approach. But the fact that you're learning how to speed up processes, because that's what most people want, right? They want to go to a physio and they want it to problem to be solved. And I think that brings up another point of beliefs around someone solving pain, is that it's never the physio's job at heart, right? It's never the coach's job. It's never someone else's job to solve pain, right? It's the person's job, right? Like all the person you're going to see is giving you a tool, and then it's your job to apply the tool. And I think we've all seen someone like do an exercise that helps them get out of pain. Like, oh, this was fantastic. And I'll never do it again. I'll just wait for it to come back.
I always find it's a fascinating topic, and if I came to you and I said, take away my sense of touch, it just doesn't make sense, does it? Or if I said, take away my sight, like it doesn't make any sense, but people might come and say, can you take away my pain? It's like you can't pluck pain away from people. It's a biological output for a purpose. You can't remove it. It's a tough thing to navigate, and to navigate the expectations of people. And I think one of the first things I do now, which I maybe struggled with as a junior physio, is to create that expectation that this is going to be a process, that they're going to experience some symptoms and pain, that it's safe to experience those symptoms and pain, it's safe to move and exercise and experience pain on a daily basis, okay? And creating that expectation that we're not going to take away your pain. You are going to stay in pain, but we're going to change the aspects of your life that are contributing to your experience. And sometimes it's managing something entirely different, which you may have come in, and it's tough sometimes, because you do have to sort of navigate that very delicately. If someone comes in with pain and an expectation for you to take away their pain, you can't just say to them, oh, well, I can't take away your pain. Like that's going to break that relationship instantly.
Yeah, they've got to have some trust as well. They've got to have a buy-in, as we And
sometimes it does take a few sessions or a few times of seeing someone before you do have that buy-in and that trust, that you can start to have those more difficult conversations about what may be driving their condition.
I think that's one of the most impactful things that's been said through the poddy so far. Like, that is an honest, hard conversation. But if you can get that person to be introspective and kind of accept that, that's huge on their recovery process. I wanted to make sure we have the time for this question, and it's more of like an ending, and we can circle back to something else afterwards.
Who's your favourite Star Wars character?
But when someone is out of pain, what are the next steps for that individual? Is it just done, dusted, back to normal habits? Or what should that person kind of address or focus on once pain symptoms have subsided?
It depends on what the driver of the pain was to begin with. So maybe if I give 2 examples. So one would be someone that has Achilles pain and they're a runner, and they've been managing it over a period of time, and to the point where they've got very low symptoms or low, let's say, no pain. It'd be silly for them to go back to the activity that they did that incited the pain to begin with. Like, it's a process, it's still a management process, a preventative process that needs to go on.
And that activity isn't just the activity, it's that dose of the activity.
Dose of it,
that's the first thing that pops into my head is runners. They're just a different breed when it comes to this stuff. And it's kind of like, okay, well, so the pain subsided when you didn't run 5K every day, you run 4. But the second they feel better, they're running 5. Guaranteed. Like, they're not going to slowly build back up. It's kind of that runner's nature. But sorry, carry on.
The second group is probably almost a bit different, because some people will just never escape pain. Like, they will live their life with back pain or live their life with neck pain. It's not uncommon. And it's more for that person to know what things they can do to manage their condition as best as possible. So it's like, I know I need to manage my mental health. I need to have regular reviews with a psychologist, or I know that I'm going to need to check in with my GP about my XYZ condition, or I know I need to see my physio about, this particular problem, or I know I need to be exercising. So it's more of the maintenance process for that person. So you've got the person that needs to prevent, and you've got the person that needs to maintain.
This puts me on to another question. We're running out of time, but so say for example you do have someone with pain, and they have, say for example, their own coping mechanisms that, and then you have a thought process as well. So how about certain coping mechanisms that actually they don't actually change the cause of the pain, but they relieve the pain for short periods of time, right? Where I can see the benefit. Some people put too much hope in them things and not enough on actual, like you say, graded exposure.
No, I agree. And sometimes I see, I'm going to call them red flags in the way people do cope, in that I can't tell people how to cope best, but I can sort of identify things that are associated with maybe like an external locus of control, for example, like believing that someone else is in control of their situation when I think that they have the skills themselves, or there's a misunderstanding of the mechanism of what's happening that leads to that. So say, for example, someone is, I'm not going to hate on chiropractors, but they'll be signed up to a chiropractor to, get manipulated 3 times a week for 6 months. And it's not uncommon to see something like that. And to me, even if they feel better from that, I think it is a failure to understand the adaptability of a human and the resilience internally that we have for that to continue on. So I think that person has the skills to help themselves, but they just need a bit of guidance. And I think that's probably what I would be looking at there.
Yeah, so well said. Really, really well said. I think that's incredible. And I feel like it's kind of a sad case sometimes when you see it, because again, they do have a belief system, and the belief system is so strong because they feel good when they do it, right? Like, but are you paying attention to the root of the problem?
And sometimes the funny thing,
both.
Yeah, and you're right.
Get it from both ends.
And sometimes they don't actually get relief. It's more just that procedure gives them a sense of control, that they feel like that is, I need to go through these steps. My self-efficacy comes from these steps, or X, Y, Z, seeing a chiropractor, getting a massage, getting this done to me. That gives me control. Even though I don't really feel too much different after it, at least I'm doing that to help myself.
Or the reliefs are misunderstood to themselves. Like the relief is like for massage doesn't have a ton of information behind it, but it's social environment. Like the relaxing music. They're lying down in the middle of the day where they don't get that midday nap. The touch of another human being. Right, we could, if they actually start understanding why this might be helping them, they might be able to take approaches to other things in their life that actually can fulfill that even further.
Powers that's within them, like they're the one that's
created that. I thought you were about to say the powers within. I was like, oh, that's deep.
well, the power is within them to create that change. So it's their nervous system that's changing. It's not the person that's changing them. They're just receiving that stimulus.
I think there's 2 things in play, right? There's that short-term relief system to the nervous system, get parasympathetic, get calm, get social. I know, do foam rolling, whatever you like in the short term, but there's also those delayed gratification strategies.
Yes.
Changing your environment, changing your social group, addressing your
Habits,
mental health.
like things that are really going to make a difference.
100%. And they might not like be impactful straight away, but they compound and they change how you experience the world.
I have another question on that. Like, so we're talking about habits. Like, whereas we know that we need to build good habits, like, do you often see like habits with people that are like detrimental, like where it could be like you are doing too many of these things? And do you ever take things away from people as well as give them things?
Very regularly. Sometimes the consult is just taking things away, and it could be like I've got knee pain. It's, very recently I had someone that said that they had knee pain and then they had a tight ITB. And then the person was prescribed by another health professional rolling of their ITB, and like I'm talking about aggressive rolling of their ITB, and they said to me, my ITB is still tight and it's still sore, but it's getting better. And I'm like, how did they determine that was tight to begin with? And then how frequently, and they were judging the success based on how much pain that they experience on a foam roller, which is a completely different.
And foam rollers do not release ITBs. Like that's
yeah.
A bus probably won't release your ITB.
Yeah. Maybe another example is someone that's doing lots of stretching for a problem, like they're just constantly reaffirming that there's a problem by taking it into a painful stretch. Or it could be someone that keeps poking a spot on their body. It's like this part's sore and they constantly poke it, or they constantly squeeze it and it's like this part's still sore. And I'm like, have you stopped poking it yet? And then they would be like, oh, well, it doesn't actually hurt when I don't poke it. But the problem is that I'm actually poking it.
Yeah, you're just reaffirming. Yeah. Does it still? Oh, it still hurts. Oh, poke it again. Yeah.
That's a tough one to navigate when someone's like, oh, my Reiki healer said that I need to internalize my energies over here to reduce this. And you're like, fuck. And like, you've got to work around it, but also advise something impactful at the same time. Like, you can't just go, oh, that's all shit, that's all crap. Like, you need to do A, B, and C. So it's a tough one to dance around when someone has been advised something that actually maybe their time could be better spent, or actually it's maybe not returning anything back in investment.
Yeah, and I definitely see it as a game of give and take, but I do see things as interference. Like, I do think like you might be doing the best you can do, and then they're doing that stretch that I'm just testing to see if it hurts. Oh yeah, it still hurts. So what you're doing is you're igniting the nervous system of the body for the pain, and then you're just like, good luck getting rid of that now. Yeah. Like, well done.
One of the principles of pain management is cognitive and behavioural treatment, right? So, and that's under that's implying that there is some adverse cognition or some altered behaviour, movement behaviour that's contributing to the problem. So that's the core treatment, isn't it? So it's like your belief that you're injuring yourself when you do this, but it's not true. You're not injuring yourself. You can't injure yourself doing a lunge. Versus or a behaviour is like I'm avoiding bending because I injured my back 10 years ago when I was bending doing a deadlift, so I'm completely avoiding it, and now that's guiding my hypervigilance, that's guiding my muscle tension, that sort of thing, whereas the treatment would be to do the opposite. So I think very often the treatment is to do the opposite, especially in persistent pain.
And you're just putting out there right now that there's a lot of bad information out there. Like it is tough. I do think people should get recommendations when they go to someone, like see someone who knows what they're talking about as well. I think that's super important, because there's still this funny belief out there that foam rollers do release like that kind of muscular or the tissue, the fascial tension and stuff like that, which is whack and been very much misproven, right? There could be like a 0.5% neurological change by dampening the muscle tension. Well, we kind of know that it does dampen the muscle tension, right? Yep. And if you keep doing that, we might get like a slight effect, but not if you put in as much weight into it as possible and expecting a certain outcome.
You could also say that you can habituate to a task. Like, you can habituate to foam rolling just like a martial artist can habituate to kicking bamboo. Yeah. Like, it's over time your nervous system adapts to that stimulus, and then maybe that's why the pain reduces. It's got nothing to do with the actual biomechanics of the tissue. So, This is another kettle of fish, right? Like, I would love to get down this route a little bit more, but I think it's starting something new that we probably shouldn't do right now. But maybe we have to have you back on and we'll have to discuss a bit more in detail, kind of like maybe fallacies and like truths of kind of what you are doing, what you're not doing when you're doing certain things. Yeah, that'd be great. Yeah.
Well, thank you very much for your time today, Michael. It's been an absolute pleasure.
It has been. Thank you
very
much.
Thank you.
Thanks, mate.